Thank you to the organizers for the opportunity to present today. I'm Keith Westby, Chief Operating Officer of Iveric Bio. At Iveric Bio, we're developing transformative therapies for retinal diseases, and we're focused solely on retinal diseases. Multiple studies have indicated that complement plays a major role in the pathogenesis of AMD. And if you look at the complement cascade, it looks a bit complicated, but it's really more redundant than it is complicated, with 3 different independent pathways that all converge at C3 and then C5 and end up in the terminal complexes inflammasome and the C5b membrane attack complex. Avacincaptad-pegol, or Zimura, or ACP as I'll call it today, is a potent and specific inhibitor of complement factor C5. It binds to C5, inhibiting the cleavage of C5 into C5a and C5b, both of which inhibit cell death. Now, importantly, Zimura preserves the C3 pathway, which we feel is important for safety. I'll talk to you a little bit today about GATHER1 and GATHER2, which make up our phase 3 program for geographic atrophy. GATHER1 was an 18-month study studying multiple doses of Zimura against sham. The primary efficacy endpoint was at 12 months. These are the inclusion-exclusion criteria. What I'll point out is one specifically is we included patients, only patients with non-foveal GA. So the efficacy from the study, both the 2 milligram and the 4 milligram doses hit their primary efficacy endpoint at 12 months, showing a difference of about 27 to 28% between the sham and the treatment arm in the growth of geographic atrophy over time. Now, importantly, this continued on, as I mentioned before, this is an 18-month study. This continued out to 18 months, and we saw the separation as early as the first time point we measured, and this continued out to 18 months. In terms of safety, avacincaptad-pegol, or ACP as I'll call it, was very well tolerated over the 18 months of continuous therapy. There were no ACP-related inflammation. There was no endophthalmitis in the study. The most frequently adverse events reported were related to the injection procedure itself, which were as expected. In terms of CNV incidence, the 2 milligram dose, which we forwarded into GATHER2, had an incidence of about 9%, or 6 patients in the 12-month time period, and 11% at the 18-month time period. And if you just for reporting purposes, this is all CNV, whether it's exudative or non-exudative. Key takeaways from GATHER1: met the primary efficacy endpoint at 12 months for both doses, the 2 milligram and the 4 milligram. We saw early and continuous treatment effect over the 18 months, yielding a 28% reduction in the rate of GA growth over that time period. ACP was very well tolerated, and the most commonly reported treatment adverse events were related to the actual injection procedure. Importantly, what I didn't get some time to talk about are the post hoc analyses that we've performed and presented most recently, and you'll see some Saturday at ASRS, but they've indicated that ACP may have the potential to work earlier in the disease process. And you'll see some of that data on a conversion from iRORA to cRORA, as well as drusen to iRORA and cRORA. And this could change the natural history of the disease. GATHER1 results led us into the GATHER2 study. This is a 24-month study with a primary efficacy endpoint at 12 months of monthly injections over those 12 months, looking at the 2 milligram versus sham. Importantly here, one of the things that we really focused on was patient retention during this trial, especially during COVID times. And we think the best way to measure patient retention is by what we call injection fidelity. That's the total number of injections administered divided by the total number of potential injections through that time point. We set out a goal to have over 90% injection fidelity, and as with the last report just a few weeks ago, we were well above that measure. We recruited the last patient in July of last year, so we expect top-line data in this third quarter of this year. Now, the study will continue on for 2 years. At the end of 1 year, patients in the treatment arm get re-randomized to either continue on monthly therapy or move to every other month therapy. And we see that here. So that's the design of GATHER2. We're very happy and pleased that we have a clear regulatory path forward with one of the first SPAs in the geographic atrophy space. So we have a special protocol assessment agreement with the FDA. I want to thank all of our GATHER1 program investigators and patients, and also thank you all for your attention.